suspect will join us in the next few minutes, but I have the distinct pleasure of introducing Dr. Hannah Oh, and she comes to us from New York primarily. She got her undergraduate degree at New York University and a medical degree at Rutgers in New Jersey. And then she did her residency and PMR at New York Presbyterian Hospital, Columbia University, and Weill Cornell. And then she completed a fellowship in cancer rehabilitation at MSK. And she's got a host of talents. She is both an assistant professor at the Department of Rehab Medicine at the University of Washington, and also a certified lymphedema therapist. She joined us a few months ago, and we are delighted to have her. She serves as the first medical director of cancer rehabilitation at SCCA. So.
Great, thank you so much for the introduction and inviting me to give this talk. Let's see if I can get this screen share. So as Dr. Young mentioned, I'm the first physiatrist and medical director of cancer rehabilitation at SCCA, also certified lymphedema therapist. Not that I'm doing a lot of the bandaging or manual and lymph drainage techniques in my clinic, but it's helpful in getting a sense of what patients are doing on their own in terms of home exercises, as well as just understanding the language of what our therapists are doing in clinic. So first, I want to share a little bit about physiatry. I get this question often. I'm often sometimes confused with a physical therapist or a psychologist or anything else that probably starts with a PH, but I am a physiatrist, also known as a rehabilitation medicine physician. In terms of what physiatrists do, the subspecialties are quite broad, but overall we're doctors of function. And we overall want to address any mobility or neurologic impairments that can change a patient's ability to perform activities of daily living, their jobs, their hobbies that they like to do. Specifically, our subspecialists train in brain injury, spinal cord injury, sports medicine, electrodiagnostic medicine, including neuromuscular medicine, cardiopulmonary rehab, and amputee care. And while these impairments and disease processes occur independently, we've seen a lot of crossover into the oncologic population. So we have all these resources and techniques or procedures or interventions that we provide for patients with sequelae from a stroke or brain injury, such as spasticity management or management of neurogenic bowel and bladder, and adaptive equipment that we provide patients with a spinal cord injury. And there is a parallel in how we should be providing these resources and modalities and treatment options to our patients with brain metastases and spine metastases, and the list goes on. In terms of rehabilitation in oncology care, my hope is that this becomes a standard of care and a medically indicated intervention and not just a supportive resource. In the community or general population, no one really questions the role of physical therapy after hip replacement, or the role of speech therapy or occupational therapy after someone has a stroke. And I think the case should be the same in our patients being treated with cancer. Overall, when patients do have an impairment, I think physical therapy or physiatric assessment, if needed, should kind of be a non-negotiable medically indicated intervention. It's not just exercise, but we are the experts in exercise. So rehab can include prescriptions for physical activity, precautions when it comes to mobility and exercise, but there is a lot more to rehab that I'll hopefully share in the next few slides. not only is it important to address the impairments from cancer itself, I think there is an onus on us as providers to treat some of these impairments, given that a lot of the changes in function or sequelae are from cancer-directed treatment and not just from the cancer in itself. Also, in terms of being proactive, Lexi Harlow knows I love this slide, and this is the estimated cancer prevalence by age in the US population from 1975 to 2040, and you can see the increase in numbers. And overall, as there's a changing demographic in cancer survivors, referred to as the silver tsunami, not something that I came up with, but we know what's happening to our patients, and we need to be proactive about the comorbidities and sequelae of cancer treatment, with the understanding that these patients, as they go into survivorship, will need to manage these sequelae long term. And by 2030, approximately 70% of all cancer survivors will be diagnosed among adults over 65. And there will be a demographic shift in the composition of the survivor patient population, and older patients have pre-existing comorbid conditions, which can be exacerbated by cancer-related toxicities, and a lot of this affects their mobility. Rehab and oncology care is has typically been described in 4 different pillars or categories. Preventative care, which includes prehab; restorative care, which is the treatment of impairments or musculoskeletal sequelae during cancer treatment; supportive care and survivorship, so managing a lot of the long-term chronic sequelae; and palliative care. So we know via the literature and rehab studies in other fields that rehab interventions can improve pain, function, and quality of life. And I think the same goes in patients being treated for cancer and cancer survivors. We know in rehab, the other subspecialties of rehab care, that these interventions can ameliorate physical and cognitive impairments at every stage of treatment. And again, the same goes for cancer rehab. So preventative cancer rehab is this idea of prehab, introducing modalities or exercise or treatment options before surgery, before systemic treatment begins, with an understanding of the patient's functional baseline. I'll talk a little bit of palliative care and examples of this in the next few slides. And in terms of cancer care in the continuum, so we're going to have a kind of a pretend case. We're going to disregard ages and types of breast cancer, but more so just for example's sake. So let's say we have a woman diagnosed with breast cancer who is, in her in a age group where she has some pre-existing comorbid conditions that affect her mobility. She may benefit from a prehab program for conditioning prior to starting treatment. Geriatric assessment or frailty assessment may be helpful to understand risks of falls if she were to have a neuropathy. After mastectomy, radiation, and or chemotherapy, she may have adhesive capsulitis that we can address not only with physical therapy, but sometimes injections to improve pain, to be able to tolerate stretching and physical therapy. Let's say this patient is on an AI. We can address arthralgias and musculoskeletal causes of pain instead of with just systemic treatment options or oral medications, with injections for carpal tunnel or an injection for de Quervain, and being able to target those specific musculoskeletal diagnosis instead of just, a vague arthralgia, as we do in a sports medicine practice. Let's say this patient is in a stage where she's considering going back to work. We can consider work conditioning, physical therapy or occupational therapy program, introduction or meeting with a vocational counselor to talk about work accommodations or resources. If this patient has lymphedema, check-ins with a lymphedema therapist or a physiatrist to assess fitting of garments and how effective her home self-massage or bandaging for maintenance is going. In patients with metastatic disease, let's say bony metastases or CNS involvement, a consultation with a physiatrist may be helpful to counsel patients on mobility precautions, exercise precautions, return to activity to prevent pain, or but also focus on strengthening. In cases where the spine is involved, spinal cord injury medicine is a huge part of physiatric care, and not just in terms of pain management, but being able to offer medications for neurogenic bowel bladder training, wheelchair fitting, bracing, and particularly even in the palliative setting, rehab providers, including therapists, can play a huge role in caregiver training, adaptive equipment, counseling, and this is I think a critical need overall in terms of rehab playing a role in the palliative care setting. Just understanding that hospice, inpatient hospice or home hospice often does not have the resources or provide mobility training, counseling, or caregiver training, but it can play a huge role in terms of addressing patients' ideas of dignity and mobility and independence when mobility is involved. And while I obviously think this is critical, not just my opinion, but rehab is now part of NCCN and COC guidelines, with COC guidelines describing rehab care services as an essential component of comprehensive cancer care. And this is not to say that every patient diagnosed with breast cancer should or needs to see a physiatrist, but overall the goal or the vision of cancer rehab, particularly at FECA, is to be able to triage these patients into say different categories, but understanding what they need at different stages of cancer treatment. So some patients may need to just be reminded or educated on what the ACSM guidelines are for exercise and return to their prior level of activity, which can be self-guided. Some patients may benefit from having a course of physical therapy to address shoulder dysfunction or learn how to manage their lymphedema, while others, depending on comorbid or complex medical conditions, may benefit from a physiatric assessment or an injection for a musculoskeletal condition, bracing, etc. And this is constantly in flux depending on patient symptoms and stage of treatment, but overall, something that we want to be mindful of. So in terms of my role or the overall goal of cancer rehab, we're hoping to introduce the importance of functional assessments, but also make functional assessments a mainstay in terms of how we're evaluating patients, and not just how their disease is progressing or surveillance, but understanding what patients' mobility baselines are and being able to advocate for the right rehab resources to get patients to their optimal mobility state. We can also reduce symptom burden with by addressing the musculoskeletal neurologic sequelae and treating them as distinct entities. And one of the, not the most powerful in terms of number of participants, but impactful studies was by Andrea Chaville in 2008, where she just looked at 163 women with metastatic breast cancer. And of these 163 women, she was able to find that there were over 500 physical impairments that were identified in this group that would benefit from physical therapy and occupational therapy, but only 30% of these patients with this abundance of changes to their function received this care. And as we introduce or implement rehab resources in the cancer care continuum, we hope that we can just improve quality of life and that's focusing on patient goals, whether it's return to work, return to activity, or just safety in the home with activities of daily living. So as the physician working with this team of physical therapists, occupational therapists, lymphedema therapists, and speech therapists, my role is to help in diagnosis, prescribing certain things, and providing some education and counseling. When it comes to diagnosis, we want to be able to identify issues and address impairments before they become disabilities. And that can be understanding the severity of a chemotherapy-induced peripheral neuropathy with a EMG, and understanding if there's another neuropathy also complicating the picture, if there's something paraneoplastic going on. If someone has a weakness, maybe it's deconditioning, but maybe it's a mononeuropathy, or it's a neurologic cause, or it's a tendonitis or a partial tear of a muscle. But being able to diagnose what is causing the change in function can be critical in understanding what physical therapy interventions are going to be the most beneficial and effective. In terms of prescribing, well, I do prescribe some medications for neuropathic pain or neurogenic bowel bladder management or spasticity. A lot of the prescribing that I'm doing is for bracing, splints, orthotics, spine bracing, as well as physical therapy and other adaptive equipment. In terms of education and counseling, a lot of it does involve exercise. And the common saying is that exercise is medicine, but if that's the case, we have to be mindful of dosage and frequency and what that really means. So if depending on the diagnosis, should the patient just be walking? Should we be focused on interval strength training, more isometric contractions, or, and should we be refraining from repetitive weight-bearing dynamic exercises like someone with a femur bend, who probably shouldn't be doing jumping jacks? And some of the counseling is on orthopedic precautions, but it's specific to the patient. So depending on what work is like, depending on if they want to return to golf or ski, part of my role is understanding what their capabilities and pain is currently and how we can work towards improving that over time. And I see this as how we kind of view and treat athletes. A pitcher with a shoulder injury doesn't just have physical therapy and start the next game. It involves a team of sometimes a sports psychologist, nutrition, athletic trainer, physical therapist, as well as a physician and a team doc to create a plan that's multidisciplinary, that makes sense for the patient. And they'll go through range of motion exercises, physical therapy, practice playing with the team before returning to game time play. And I think the same goes for our patients. So again, not everyone being treated for cancer needs a physiatrist or a rehab team. There are some patients who are able to, who are achieving this goal of 150 minutes of aerobic exercise and a few times of strength training during the week, but there are many who are not. So how do we figure out which patients should see us? So there are algorithms and pathways that have been suggested, but overall, it can still be a little bit challenging to figure out who would benefit from a referral. And overall, I like to think of this in terms of two different categories, based on a patient's impairments versus the presence of a chronic disease. With common things being common, in this presence of a chronic disease category, we know that while patients are being treated for their cancer, they still might have degenerative changes to their spine, arthritis, carpal tunnel, and we can treat those as specific entities. And sometimes patients do have a history of MS or a stroke or muscular dystrophy or other neuromuscular condition, which should prompt a referral for further monitoring of their function as they undergo treatment, or other cardiorespiratory disease that complicates their physical activity, and a provider may feel uncomfortable just telling them to, return to walking or exercise as they were doing previously. In terms of this impairment-driven rehab category, these are the patients who have a change in physical activity from their cancer diagnosis itself or a sequelae of cancer-directed treatment. So that can include bony involvement, CNS involvement, lymphedema not managed with current garments, and manual drainage techniques, etc. A new neurologic symptom that impairs function. So not everyone with peripheral neuropathy may need rehab services, but if it's playing a role in terms of needing a new adaptive device, tripping, fearful of walking, may necessitate further workup and intervention. And we'll shift gears a little bit towards my practice and the start of the cancer, or the building of the cancer rehab program at FCPA. In terms of tools that I utilize in my clinic to address some of these symptoms, some of them are ultrasound-guided joint and soft tissue injections to treat the orthopedic and musculoskeletal diagnoses that are playing a role in change in function. So that can be arthritic changes, that can be tendinopathy, carpal tunnel, bursitis, etc. For patients with radiation-induced changes, more so for the head and neck population, with like cervical dystonia or trismus, we can utilize Botox, which we also use for management of spasticity from CNS causes. And my colleagues in the Department of Rehabilitation Medicine trained in more pain procedures and spine injections would be able to do other things like nerve blocks and fluoroscopically guided injections, as well as EMG. And overall, I've probably said this in multiple ways, but cancer rehab is medical care that should be integrated throughout the oncology care continuum and delivered by trained rehabilitation professionals to diagnose and treat patients' physical, psychological, and cognitive impairments in an effort to maintain or restore function, reduce symptom burden, maximize independence, and improve quality of life. And I don't do this alone. The bracing and orthotics and splinting that I often order for patients is often via the great prosthetics and orthotics team at UW, which has multiple sites. I'm part of a larger department of rehabilitation medicine at UW, which has phenomenal resources outside of physicians. That includes the inpatient rehab unit at Harborview and UW, an inpatient consult service for any of your patients who are admitted and have a change in function may benefit from a in-house assessment rather than something outpatient, as well as a robust rehab psychology team. So this includes vocational counselors, rehab psychologists who help with non-pharmacologic coping strategies for patients with changes to their mobility, and neuropsychologists who can perform multiple batteries of assessments to understand cognitive function, and even for patients who have severe fatigue or feel like their processing or thinking or attention has changed throughout their cancer care journey. We also work very closely, particularly in the treatment of lymphedema, with our garment fitters at Shine, who are wonderful. And rehab doesn't go, it's impossible to do rehab without a nutrition plan. And patients who've seen me know that I tell them, if you're seeing me, there's 3 things that we focus on, and that's to eat, sleep, and work out. The sleep can be challenging, but the eating part, we work closely with our team of registered dietitians in medical nutrition. And if you have a patient who you think would benefit from a referral to see myself, the EPIC referral or the logistics of referring to me is in order, a referral to cancer rehab order. And our team, our wonderful team at SCCA, has been scheduling that via our schedulers in the rehab therapy department. I also have a clinic at Montlake a few days a week, and that would be a referral to rehab medicine. Apologies for a bit of a convoluted way to refer, but I'm happy to see patients at both locations. I also see patients on the inpatient consult service at Montlake, and if there's any patients who are coming in with any change in neurologic status, sign involvement, our team's happy to follow them while they're admitted. And that's all I got. Hopefully kept it brief and happy to take any questions.
That was really wonderful, Hannah. I would just encourage people, I don't know, I think the chat function is open. Yes, it is. Please feel free to put any questions you have in here in terms of, particular cases. Hannah's got one. I'm going to read it right off. What's the typical duration of treatment for patients?
For lymphedema, it would be a completely different course. For physical therapy, it depends. Especially, I would typically recommend patients follow with a physical therapist at least once a week for a course of like 6 to 8 weeks. And the goal is not to be, dependent on physical therapy for the prolonged course, but to kind of learn the tools to maintain and exercises to maintain and improve function over time. And some physical therapy is hands-on in terms of soft tissue techniques and myofascial release. But my view on physical therapy is really to learn the goals of to learn exercise so that they can be self-sufficient in treating their diagnosis. In terms of following with me, I follow patients regularly until symptoms improve or there is a kind of self-directed plan in place. For patients who are unable to go to physical therapy, or especially now are hesitant to go to another in-person visit, I've been checking in with them, giving them a home exercise program, and then following up within a few weeks and optimizing or changing the home exercise program, or symptoms improve and they can see me as needed.
And then another question is it generally covered by insurance, or could you speak to maybe insurance issues?
Sure. In terms of seeing me, I have not seen any challenges. In terms of physical therapy, there are limitations depending on insurance in terms of how many visits are covered. And that's kind of typically a pool, I think, of therapy in general. And not specific to like PT, OT, or speech. So if patients have, but overall, I think it differs by insurance. In terms of challenges, cost-wise, or things that can be cost prohibitive, specifically lymphedema related. And our goal is to unify the lymphedema therapy services across SCCA and UW so that services are equitable in terms of cost for bandaging and supplies, and there is more of a pathway to refer to specific garment fitters and teams that we've vetted throughout the years.
A few other questions. I think you're going to get lots of questions because we all are so excited to have you here. Hannah asked another question, wondering if you've seen any patients or had particular challenges for patients who are on immunotherapy?
Yes, and that can be from anything from systemic side effects of immunotherapy, that they're in the neuromuscular GBS type sequelae. What's the other word I'm looking for? Inflammatory arthropathies. So it runs the spectrum. Previously, we worked pretty closely with Room in terms of diagnosis and workup, but a lot of the treatment is still rehab focused. So often not a surgical answer, but exercise and physical therapy or occupational therapy based.
That's super helpful. Lexi just added that Shine supports patients by having financial assistance programs for the garment, compression garments for patients who have limited resources. So just putting that information out there. And then Shweta asks a good question that I feel like really kind of gets at much of what we're thinking about, which is there bandwidth to see patients undergoing chemotherapy for early stage cancer? So I think one of the things that we're all thinking is, oh my gosh, this would be an amazing resource for all of my patients, and really trying to think about how to best utilize your resources. And I think that your laying out of the strategies was really helpful. And you know, are we looking to develop a program for all these patients? Is it best to refer to you or to PT and OT? And I think you kind of went into some of that, but maybe I'll ask a few other specific questions, and just gratitude for being here. So I can't say this for sure, and I don't see that Sarah is on, our service line manager, but I think maybe we've approached you about potentially being part of our survivorship cancer series, and that there's work in place. So I just wanted to say that, and if there are particular topics that people are interested in having you speak to in that series, I think that would be amazing. So if people have suggestions, please put them in the chat, and we can kind of take that offline and maybe provide some more support. Because I was thinking, yes, that it seems like that there may be an opportunity for like a prehab kind of video, a sort of during chemotherapy video, and during endocrine therapy video that people could potentially utilize. And then wondering about sort of, when do we make that escalation to actually put in a referral to you? So one of the patients I was wondering or thinking about is my patients who have really persistent carpal tunnel in trigger fingers in the setting of AI use. And you've rotated through all of them and they have it with all of them. Is that somebody that you would want to see, or can you say where like the best place for those patients might be?
Sure, I think definitely when patients have persistent tenosynovitis or carpal tunnel, or a focal musculoskeletal area of pain on an AI, I'm happy to see them, especially for patients who are contemplating not continuing therapy because of this particular side effect. And I think it's definitely worth not only trialing injections, but bracing and just providing the education of exacerbating factors, understanding what activities that they're doing to possibly make symptoms worse. Because overall, yes, these symptoms occur, but typically pain doesn't come out of nowhere. So we want to understand from a musculoskeletal kind of sports medicine-esque perspective of what is triggering these symptoms to be so ongoing, and also target and treat them locally with a corticosteroid injection, if that could be the case, or bracing, so that they can use their hands, typically affected, instead of coming off treatment. In terms of overall bandwidth and timing, the earlier the better. I think physical therapists would always agree with me. Like, we always want to see the patients before the fall happens, and the same goes for other, sequelae of like, we want to see lymphedema, or I'd like to see these patients with, worsening lymphedema. Once, from your perspective, it's not from a malignancy related cause, before the arm is fibrotic and difficult to move, and before the shoulder is so tight that, range of motion is challenging. So earlier the better. Pathway wise, our goal, I think, over the next few months to year, as we get this program built, is to formalize these in a way that the primary teams are not going through this whole triage convoluted pathway to understand, like, these patients have these comorbidities and now it's the time to refer to cancer rehab, but more of a streamlined stage-based approach depending on cancer type and what stage of treatment they're in.
I think people are excited about the videos. We showed a couple at a breast meeting a few months ago, and they were reviewed well. And I guess I just feel like it's a good way to potentially get your knowledge and expertise out there and to our patients without using so much of your time. I also think that, truthfully, actually, they may be really beneficial for us providers to watch, because I think one of the things that, as you're giving this talk today, that I'm sort of interested in even hearing more of the nitty gritty about sort of how you manage these distinct kind of issues, and understanding just a little bit more, so that I think that as providers, many of us are trying to, it's like you feel comfortable treating to this part and then that they need more attention. But maybe if you can give us just a little bit more knowledge about these things, that we'll be able to better triage, et cetera, and maybe help the other patients that we're not sending on for more acute care, give them better information. So I think that if there are, again, any topics that people are particularly interested in hearing about, please let us know. I also think that this is an area that's ripe for research investigation as well. So a lot more on that later.
Yes, and hopefully we'll have more to share on that front too, because I think there's a large population of patients that will benefit from a supervised directed exercise, but there is also a large population, particularly in the survivorship group, that may not need this one-on-one attention or a physiatrist, but we can provide modalities, whether it's through technology or videos or some sort of program to promote the physical activity and exercise that they need, and that's more specific to them than the general population. So more to come.
Hi, I'm Megan Flanagan. I'm one of the breast surgeons. I have a question. I specifically have one patient in mind, and it's not common for most of our patients, because most people do have some level of social support. We send most of our patients home. I have a patient who's been in the hospital for almost 2 weeks, and this is totally could have been anticipated ahead of time. And it seems like virtually impossible to connect the outpatient and the inpatient, because clearly, like, this patient had a plan to, like, just stay as long as humanly possible because she doesn't have any support at home, but doesn't really need to be in the hospital. But we had to sort of wait for her to get there until PTOT could evaluate her there and then say she needs to go to home health with home health services and rehab. I'm just curious if there's any, and again, this is kind of the rare patient, are there any ways that you are aware of to sort of help with these kinds of patients who we know have sort of limited at-home resources and are going to need extra help with most, certainly PT, but maybe even more just OT type of stuff, to help get them set up before surgery, like after, during neoadjuvant chemotherapy, when we know they're struggling, to try to get them, to surgery and safely home, without needing to stay for 2 weeks.
That's the goal. And I think a lot of it is resource related. And this is not just specific to the breast oncology group, but for other groups. And I think there are kind of prehab-esque programs that are utilized. I think Lexi could probably speak better to this, but things that we look out, ask patients, or even like a quick questionnaire that's used for patients pre-transplant, because these are things that are anticipated challenges to discharge. And discharge is usually required for patients to then be seen on the outpatient and start systemic treatment, or be seen for X, Y, and Z. So hopefully our goal is to kind of utilize something like a prehab or mobility functional assessment that's not just a patient's strength in lifting their legs or walking. That function is dependent on adaptive equipment and caregiver assistance. So if they can't do these things like toileting, bathing, grooming, we should somehow need to flag them before treatment starts. So overall, trying to build this prehab program that is not just patient mobility focused, but resource and overall function focused. But we can look into kind of what the transplant team has been doing in terms of caregiver role assessment, because I think that's a mainstay before transplant happens. And maybe we can just utilize what they're doing in this group.
I'd also like to add that we did a pilot. I don't know if it's still going on. Maybe others can speak to this. Doing sort of a geriatric assessment. Is that still going on? Do people know? Anyway, that was something that we at least did for some amount of time. And I think that it may be interesting to just revive that and have you be at a conversation at the table and have a conversation about that, and maybe how we could enact some of the findings that we saw, or really try to identify those patients that maybe do need some prehab before their treatment.
Yeah. Sorry, Lexi.
Yeah, hi. Thanks, Hannah. So I was just going to speak up, and I fully agree with Hannah that it's all about figuring out early on that these patients have rehab specific needs that we can address. So if that's identified prior to knowing that they're going to have a lengthy course of treatment that could potentially put them into the hospital and have these challenges going into that, the sooner we can get rehab involved into the picture, even if, you know, it's before treatment starts and we're really getting in there, that's the time for us to start training to these things. I mean, so often in therapy, we're playing catch up, and that's really just a challenge for all of us because we weren't brought in soon enough. So the more we can do that, and if there's a way we can identify these patients, that will help tremendously. And Hannah and I are actually working on some things right now in regards to just trying to determine what resources patients have at end of life or for palliative care. And I think we could use some of that work potentially to identify also what functional limitations are just happening for patients that are, for instance, in the breast group or others that we anticipate may go into the hospital and have challenges coming out. So I think there's lots of opportunity here, but we definitely need to have some sort of tool and a screening process that we can give you all as the oncologists the ability to identify when to pull in rehab. And I think that that's really the key here.
I wonder if there's even a role for sort of trying to do some patient education so they actually know when to contact us, because sometimes patients will call and they can't move their shoulder at all. I'm like, why didn't you call earlier? So I think that I'm just wondering, I see Megan kind of shaking her head a little bit. I wonder if like how much we talk about that before, or if there's some other way that we can get this information to patients. I don't know. It's really overwhelming to get a cancer diagnosis. I think sometimes it's hard to take it all in.
Right. There is something called the SCCQ in terms of self-identifying need for specific supportive care resources. And another thing on the agenda is to make this a little bit more specific and repetitive, because I think there are specific questions that we can ask patients who are undergoing radiation or surgery of the chest wall or breast that we anticipate being a challenge. And, you know, even if I'm seeing someone in telemedicine, I'll ask them, like, can you make the field goal sign? And, you know, that gives me an idea of like what their external rotation is like and shoulder abduction. And we can probably make the questions on the SCCQ that patients are already getting more specific to this team. Notes to self.
And if I could say one comment, Rachel, I was just going to, I put this in the chat, but when all else fails, if you don't know where to send the patient or to who, just send them to PT, because we will get them to Dr. O if it's more appropriate. Right now, surprisingly though, it's actually a little bit easier, well, not surprising in my world, to get in to see Dr. O than it is to get in to see my team. But I anticipate that that won't always be the case. So when in doubt, just send the referral, and we have a fantastic scheduling team on the back end that will make sure that that patient gets to the right provider. Just important we get the referral.
Occasionally we have patients that are not allowed to see PT, and I wonder, I mean, there may be a role for seeing Dr. O in those circumstances when we definitely need somebody to weigh in.
And sorry, a question for the patients who are getting prepped or are undergoing breast surgery, do they receive an education or handout or something from the therapy team or primary or surgical team about post-op range of motion?
Yes, they do. We have both
Okay.
care maps and exercise handouts that Megan Flanagan and Chris Calhoun worked on, I believe, with Lexi here on the call for all of those, for all breast surgery types.
We also continue, although this has been a bit hit or miss, but this is work that I've also done with Chris Calhoun over the years, around just being a part of the BCSE clinic, around just the initial intake. If we identify need there, we will flag those patients, but also really look at making sure that they understand the side effect of lymphedema and what the course of that could look like. So that's also work that we continue to reinvigorate often, but we really have tried with this group to be a part of the picture early on for these patients, because we do anticipate those needs.